Okay.
Hello, everybody. Welcome to this new IATH Junior Clubs. This is the first of the year. So first of all, I want to wish you everybody an happy New Year's. Today, we are very happy to have Professor Huang and Dr. Ye. Dr. Ye is going to present us a very interesting clinical case, as you will see in a couple of seconds. Do not hesitate to send your questions to the chat, and we'll try to address all questions at the end of Dr. Ye's presentation with the very great insight of Professor Huang during the clinical case discussion. So please, Dr. Ye, you can share your screen and present the case.
Hello, everyone. It's our great pleasure to participate in this IACH meeting, IACH Junior Club. And today, I will present a case which is supervised by my PI and senior doctor, Professor Huang. And this case is about neither conditioning chemotherapy nor GvHD-Prophylaxis CD7 CAR-T treatment bridging to hematopoietic stem cell transplant. So this is a female, 36 years old, and she was admitted firstly into the hospital at December 10th, 2020. And the chief complaint of her was dizziness and fatigue for over half a month. And the patient had dizziness and fatigue for over half a month and went to hospital. Blood routine test showed white blood cell count of 76 times 10 to the 9th per liter, hemoglobin 94 gram per liter, platelets 32 to the 10 to the 9th per liter, and the bone marrow aspiration was performed on the same day. The past history, personal history, family history is normal. And she was married at the age of 24 and had one son and one daughter. So as we know that the bone marrow aspiration was done at the same day, which showed that the bone marrow nucleate cells proliferate actively with blood cell of 89%, representing AMLM2A. The blood cell account for 94.9% of total nuclear cells, expressed in CD7, CD117, CD34, CD33, CD13, which is low, HLA-DR, CD38, CD123, CD56, and PO, representing AML. Cytogenetics shows normal normal karyotype of 46XX. For the molecular side, we did NGS, which showed the CEBPA mutation at two locus, while it was not BZIP. The CSF3R mutation, WT1 mutation, and ETV6 mutation. And we also did, at the same time, the fusion gene, which did not detect anything in the usual AML panel. The bone marrow aspiration showed diffuse infiltration of immune cells with a single morphology indicating AML. So the diagnosis was AMLM2 with CBPA, CFS3R, ETV6, WT1 mutation, and it was in the Yishan 2022 intermediate risk classification. So at first, since the woman has a high white blood cell count, we treated her with hydrourea and supportive care. And we had the result of the bone marrow aspiration very soon. And we initiated the standard IA regime at just 1 day after the patient entered the hospital. And during this chemotherapy, she suffered perennial infection during low cell phase, but recovered afterwards when the cell recovered. And we did the bone marrow aspiration after this chemotherapy, which showed complete remission with MRD negative. We also did lumbar puncture to do the CNS leukemia prophylaxis, which showed normal with no blood cell in the cerebral fluid. And we did another IA regime since the first regime works. And after this regime, the patient remained complete remission with bone marrow remission and MRD negative. And afterwards, we initiated the consolidation therapy with intermediate dose cytarabine plus VP16, and the patient remained MRD negative complete remission. And we did another IA regime, which also showed good results. So afterwards, we did one HA regime, which we know, the at home, which is quite well validated in China for the consolidation and also induction therapy. We did also intermediate risk cytarabine for one more time, and we did 2 more HA regime. So this patient had already two therapy followed with 6 consolidation therapy. And so since the patient was diagnosed with intermediate risk AML, the patient did the follow-up afterwards in the local hospital. And up until May 2022, the primary disease remained MRD negative, complete remission. While in November 5th, 2022, the patient felt dizziness and uncomfortable again and went to the local hospital. And the white blood cell was very high at that time, and she came to our hospital. We did the thorough re-evaluation. At that time, the blood cell was 45% with immunophenotype with CD7 positive for the majority of cells, and other phenotype was very similar to the primary diagnosis. There is no change in the cytogenetics. And as for the mutations, there remains CBPA mutation, T1 mutation in this blood cell clone. And since this patient relapsed from the primary disease, and we did the VA regime, and she was not, the general condition of her was not so good at that time. And we did the VA regime with azacitidine and venetoclax, and for 21 days, of 7 days of azacitidine and 21 days of standard of venetoclax with 400 milligram per day. And after this chemotherapy, the blood cell decreased to 11% with MRD of 15%. But at that time, she was very fragile. After this treatment, she showed very low blood cell count for a very long time. And at the same time, she suffered vaginal bleeding continuously. So, at that time, she said she's not able to continue very strong chemotherapy. So she went back home for several months by herself. And when she came back, the vaginal bleeding was very severe, and the blood cell returned to 29%. And we did another VA regime. At this time, after this chemotherapy, it did not work. The blood cell went to 42%. And we also tried a mini clag with cladribine of 10 milligram, day 1, day 3, day 5, accompanied with a low dose RRC of 20 milligram per 12 hours for 10 days. And the blood cell decreased to 6% with MRD of 3.2%. While very, very rapidly, the blood cell returned to 30%. So at this time, as we know that we did salvage therapy, we did VA regime, and we also did salvage therapy with cladribine, and it did not work. So we decided to enroll her into the clinical trial. And after the consent of her, we put her into the steroid transplant ward of our center. And in 19th of May 2023, we performed the FC conditioning for 5 days for the preparation of the CAR T infusion, which is fludarabine, CTX, and BP16. And in 26th of May, we infused 2 to the 10 to 6 cells per kilo of CD7 CAR T with a ratio of 80%, which is prepared from his son. So after the CAR T infusion, we see a very rapid elevated, a very rapid fever with the highest temperature of 40 degrees, which lasted for about 7 days. And we used tocilizumab 320 milligram at about 7 days after the CRS, and as we suspected. And it was on the July 3rd of 2023. As we see after tocilizumab treatment, the patient temperature decreased rapidly. So the day, as we can see, it was the 12th of July of 2023. It was 6 days. It was about a week after the infusion of the CAR T cells, and we infused a haplo-PBSC from her son, the same donor as the CAR T cell. The plate engraftment from the transplant was 12 days, and the neutrophil engraftment was 13 days. As we can see here below, at the left-hand side is neutrophil count, and the right-hand side is platelet count, which shows clearly the engraftment afterwards. And 6 days after transplant, we did GCSF, and at the +9 day, because the patient was EBV negative before transplant, but the patient showed a very low grade of EBV positive of 800 copy per milliliter. And the patient showed at the 11 days from transplant repeated abdominal pain, vomit, and diarrhea. The diarrhea was below 500 milliliter per day with no rash or fever at that time. So we consider acute GvHD, which is about grade 2 for this patient at that time. So we add prednisolone 40 milligram per 12 hours from the 13th day. And we also added, because the patient also repeated abdominal pain after 2 days, so we added inacipep, which is TNF inhibitor, as we all know, 25 milligram per week, and plus supportive care. And abdominal pain relieved right afterwards from about 1 week from the GvHD initiated. And we decreased the steroid gradually. From 22 days, we decreased to 30 milligram per 12 hours. And for 24 days, we decreased to 20 milligram per 12 hours. And we discontinued the inacipep. And finally, the patient's white blood cell, the cell count remained normal, and there was no fever, and there was no abdominal pain anymore. And he was discharged. And she was discharged from the hospital plus 38 days from the transplant with very good condition. So we did follow up afterwards. As we can see here, the first the transplant was did on June, and in July, in August, in September, we did each month the bone marrow aspiration, and which showed the bone marrow remission with MRD negative, and November, which is just 2 months ago, she remained in bone marrow remission with MRD negative. So she still routinely comes to our outpatient service to see Professor Huang, and she is normal up until the last follow-up. Thank you very much. This is the case presentation.
So thank you very much, Dr. Ye, for this very clear presentation on this very interesting case with these very innovative approaches, raising this CD7 CAR T cell from the sun that was effective for these patients. So again, do not hesitate to send your questions through the chat. I will address them to Professor Huang and Dr. Ye. And will start with Professor Huang. Is this case of approaches using the CD7 CAR-T, this is a standard of care now, or this is really limited to selected patients? What is what is the current status of this project right now in your centers?
Yeah. So I think it's a good question, and because these patients suffer from the acute myeloid leukemia and relapse after the chemotherapy, so it's not reaching the complete remission after the chemotherapy again. So these patients, because they follow and or the clinical study, we have the new study about the CD7 CAR-T therapies for the lymphocytic leukemia and the myeloid leukemia, such as the patient CD7 positive leukemia cell. So until now, we have include some patients in this clinical study. And until now, we have the good results, and until now, we are go on this study. And for such the leukemia CD7 leukemia positive, and the patients receive the CD7 CAR-T therapy. This is CD7 CAR-T comes from the corrected lymphocyte from the haplo donor. This patient is come from the son. So after the CD7 CAR-T therapy, we were connected to the haplo donor stem cell, hematopoietic stem cell transfusion. Such that we can know the patients not condition regimens and not the GvHD prophylaxis, just use the CD7 CAR-T after the reaches the complete remission, and then the patient donor hematological recover totally, and until now follows a half year, and I think the patient is very successful to receive the treatment. So this year, the Asian meeting, we have the presentation of the clinical study, and total about we can show all the slides.
Yes.
And I'd like to show, and this is the Asian meeting, the slides, and we have some. Yeah.
Is it possible that we share the screen from? Okay, you can see our screen.
Yeah, you can put full screen, please.
Yeah.
Perfect.
Okay, this is the Dr. Yishan presentation and the Asian meeting. So totally we focus on the CD7 CAR-T and connected to stem cell transplantation, and where are the such as all the regimens and these are the new clinical study CD7 CAR-T treated bridge to the haplo stem cell transplantation. So totally we have to recruit the patients, and we have the two doses. One is the 2 and milli, and is 5 milli per kilogram, and totally, and we have the 10 cases, including the myeloid leukemia, the acute lymphocytic leukemia, and the T lymphoma patients. Then until now, we can see the 9 patients suffer from the CIS, just this patient, also the CIS, no ICANS, and 4 patients suffer from the GvHD. So Dr. Ye presented this case, also suffer from the GvHD, and after the prednisone and the interferon alpha inhibitor, after treatment, the patient released acute GvHD. So until now, I think the patient's survival is okay. So yeah, the median follow-up about the 15 months, and the 6 patients remained as MRD negative without the actual drugs for the patient. So this 1 year overall survival and the disease-free survival are 67% and 54% respectively. So I think such the patients is very good results. Also, we detect the expansion, the CAR-T, and we can see that all patients CAR-T expansion and the maintenance in the peripheral blood cell. So I think another is we can see the CD7 negative T cells expansion also in vivo. So also we will detect such as a clone evolution. We can see here, and maybe see the CAR T cells, and the T cells can be the anti-leukemia cell. So we also detect the RNA-seq indicated no CD7 gene exon mutation for the relapsed patients. Yeah. So the 10 patients is all the clinical study, and IT is the principal investigated sponsor study. We use the Hepro donor CAR-T target the CD7, including the myeloid leukemia, lymphoid leukemia, and the lymphoma patients, and bring it to the Hepro stem cell transplantation. So we call this the regimens no condition and no prophylaxis. So I think in futures we'd like to expand the patient number and the cases, and maybe we will follow the long-term survivor and how about the outcome. So thank you.
So yeah, thank you for this. Is really great to see this data again that were presented at the ASH meeting, and that again are very impressive. Just to be clear, for patients because you show that we have a long-term persistence of the CD7 CAR-T. So, but the fact is that patient after the CAR-T cell, there is some important cytopenia. So this is the reason why the haplotransplant is mandatory, because we could expect that maybe for the disease control, the CAR-T may be maybe enough. What is your opinion regarding that?
Yeah, for the CD7 CAR-T therapies, some patients always suffer from the pancytopenia, and maybe the long time the pancytopenia and follow the severe infection. So before we will study and first we will CD7 CAR-T therapy and connect to the allogeneic stem cell transplantation, maybe use the condition regimen again. But such the patients always suffer from the long time the pancytopenia. So all now we will have the new clinical study, and I think the totally connected to the CD7 CAR-T and the hematopoietic stem cell transfusion. So I think the benefit is we will short time the pancytopenia, and such the hematological the hematopoietic stem cell, the hematological reconstruction is very scary, and we can see the patient just about 12 days after the transfusion, and the white blood cell and the platelet recover. So I think maybe we will combine the such the benefit and the advances of the CAR T therapies and the stem cell transplantation. So I am very encouraged and such the study.
Yeah, and to have this kind of combined platform. Now, if we go back in the patient story, I have a question from Dr. Ye, because in fact, this patient has an intermediate risk acute myeloid leukemia. But if I see seeing well, she did not receive a stem cell transplantation in the first line. Just why did you discuss the stem cell transplant in the first line? Why did you decide not to perform a transplant as a consolidation therapy as a first line, Dr. Ye?
Thank you, Florent. I think this because she manifested she came to our hospital when she relapsed, and all the chemotherapy was done in the local hospital. And we can understand because it's intermediate risk AML, and maybe there is no way to do transplant at their hospital. So that might be the reason that she did not receive transplant at the first line consolidation therapy. And also maybe the local doctor just say that, okay, it's intermediate risk and you already done consolidation therapy, two induction and 6 consolidation is enough. So we can see that she did the follow up in the local hospital then she relapsed and she came to us. So I think that's might be the reason.
Yeah, I understand better like that. Sure, I understand. So yes, this is a question. It can be, we can debate if we perform transplant in this setting. And since she was in the hospital, as I did not perform transplants, I did not do it. And after in the second line, of course, she need to receive this kind of treatments. And regarding after the transplant, so she developed acute graft-versus-host disease. You treat with steroids. I also see that you use etanercept, anti-TNF alpha.
Yes.
We know that now that we have also ruxolitinib, so that is also very effective. So just to understand, what is your criteria of choice to treat steroid refractory acute graft-versus-host disease? Did you use steroids plus something else in everybody, or how did you choose?
I think this is because for the treatment of acute graft-versus-host disease, we follow the criteria and we follow the steroid refractory. As you can see here, first we use the steroid and did not respond, and then we go to the second line. And indeed, for this patient, we use a TNF inhibitor because she at that time we think that, I don't know if it's really this case, that TNF inhibitor did not affect the cell growth as compared to ruxolitinib. And also for this patient, indeed, in our center, so after the TNF inhibitor, and she recovered. So I think this is also a successful second line therapy. But also in our center, we had for some very severe cases, we will use ruxolitinib together with TNF inhibitor. And I think we published this study several years, 2 or 3 years ago, and it showed a very good result. So I think this patient, we are just making a balance because we are afraid that she will lose engraftment, and the pancytopenia might be severe after ruxolitinib therapy.
Yeah, so in fact, your answer, it was what I was expected. You say that maybe ruxolitinib may also have an effect on the CD7 CAR T cell because they persist after stem cell transplantation. If you use ruxolitinib, they may have an effect on this kind of the CAR T. So this is why you decided to use anti-TNF alpha. It completely makes sense, and it was what I was expected when I asked you the question. So this is what I understand well. No, so very nice, and happy to see that the patient is doing well still until now. Regarding the choice of the donor for the CAR T and the stem cell transplantations, you only use haplo. Did you also use for some patients some perfectly matched family donors from the sibling, or this is only with you can only doing using haplo from the sibling or from the children's?
I think this is because this trial is done in the haplo setting, and in China we do 70% of haplo. So that's why I think this kind of haplo is donor is is easy to get, and the match sibling is even more difficult in China as compared to haplo in most cases. So I think that's the reason. And anyway, I think your suggestion is also works when we have a matched sibling, we can be a donor of CAR T cells and at the same time the transplant. So that's the case, I think.
We could expect that. And I have a last question, maybe more for Professor Huang. Regarding the treatment before the CAR T cell, you use fludarabine, cyclophosphamide, and you also add the VP16s. This is not classic because most of the time we use fludarabine, cyclophosphamide. This is to have a better persistence of the CAR T, a better T cell depletions. Why did you decide to add these drugs into your conditioning regimen for the CAR T?
Yeah, so we have because our sentence has carried out the many cases the CAR T therapies. Before we all use the CAR T the conditioning regimens, and we use the fludarabine and the cyclophosphamide. And before for the CD7 CAR T therapies, and we think that we should enhance the such as the immunosuppression. So we have to design a new conditioning regimen before the CAR T therapy, and we use the fludarabine and the cyclophosphamide and the VP16, and we can see the VP16 can enhance such as immunosuppression and improve and such as the effect. So in our study and the clinical study, and we have some studies just like another target CD20 and another CD19, and we have all the new conditioning regimen for the CAR T therapy.
Thank you. Because I thought also this is a very interesting finding from your study, because in some patients that, for example, we have some kind of CAR T cell production failure with the low doses of CAR T cells, and we say what we can do to improve the engraftment of the CAR T cells and to enhance the proliferation of the CAR T cell, and we need this new kind of T cell depletions conditioning regimens, and I think that the VP16, as you show here, could be very interesting to be added in some selected patients. So it was also a very interesting things you discussed today. So now I think we're going to an end of this IATH Junior Club. So I don't know, Dr. Ye, Professor Huang, if you have a last comment you would like to do, so please.
Yeah, so it's the first time we will participate in the IACH, the Junior Club's case discussion. So it's the great honor and also pleasure to participate in such a club. So I think until now the hematology many advances science and technology, and was used in the hematological disease diagnosis and treatment. I think the recent 10 years is very remarkable advances is cellular therapies and CAR T therapy. And before all we use the CAR T treated the B lineage malignancies, just like the leukemia and the lymphoma. So until now, I think the myeloid leukemia is a great challenge. Use the cellular therapies. So today we will record this is the new case, use the CD7 CAR T and connected to the stem cell transplantation. I think in our sentence, we advances hematological hematological stem cell transplantation. Every year, we perform more than 500 cases of stem cell transplantation. The majority, about the 70%, is haploidentical stem cell transplantation. So I think that we can connect it such as advances technology, just like the stem cell transplantation and the cellular therapies. Maybe in future, so we will connect it to such as the targeted therapies, and we can create a new protocol, new methods, new regimens for such patients. So today, Dr. Ye and or the young doctor, and he also training in the follows Dr. Moti. So I think is a very excellent young doctor. So so today is provided such as a case. I hope and maybe in futures we can enhance the communication with the French doctor colleagues and another countries colleagues, and we can communicate with each other and cooperation in futures. Thank you.
So thank you very much for participating. I really think that you are moving the field forward in the field of CAR T-cell therapy, of stem cell transplantation, as you show here with these very innovative approaches and very successful. So congratulations and thank you again for sharing your experience today. I will be happy to see you again very soon during the EBMT meeting.
Yeah.
And, to all participants, thank you for attending. If you have some interesting clinical case to present, to suggest, do not hesitate to email me or to email the IHCH with your suggestions, and we'll see all of you very soon. So thank you. Take care. Goodbye.
Yeah, thank you. Thank you very much. Bye-bye.